All right, so today we're going to discuss left to right shunts. So this is the diagnostic set here of increased pulmonary vascularity. Remember, in congenital heart disease, we always start with the pulmonary vascularity. Patients are acyanotic, so you're in the category of shunt lesions or left to right shunts. So the most common of these, ASD, VSD, PDA, endocardial cushion defects, and then these are the less common, the diseases that will give you left to right shunts. For these AV fistulas, coronary artery fistulas, the even ruptured sinus valve, aneurysm, it's not the left to right shunt component really that's going to be significant, but the other problems with these are going to be more significant than the actual shunt flow, the actual left to right shunt flow. So when we're talking about septal defects, you do have to, it helps to understand them if we know something about the embryology, about how this septum forms that separates the atria from the ventricles. So the heart starts out as this hollow tube where all of the chambers communicate here in the middle, and then we have the septum primum that's going to come down and it's going to join with the endocardial cushion. So the endocardial cushions contribute to the formation of the inferior aspect of the atrial septum and the superior aspect here of the interventricular septum. And then as that septum primum comes down, as it comes down, it closes this big hole in the middle, which is the ostium primum. And so if it does not fuse completely, then that's how you get your ostium primum defects. Okay, and then you have that septum primum develops holes within it, which is the ostium secundum. Then you have the septum secundum that comes down and then covers the rest of it. And then when you're all done, you'll have this kind of appearance here where you have the foraminal valley that goes through and allows shunting from right to left during embryology because the lungs are not functioning, so you need that right to left shunt in embryology. So it's a nice movie here illustrating how we get this separation. Here's the endocardial cushion, that's your septum primum, there's your septum secundum, and then you're left with the foraminal valley that allows your shunting there during development. Okay. So the most common atrial septal defects will be septum secundum defects. So these are big holes there right in the center of the atrial septum. And then if there are problems with development of the endocardial cushions, then you can have atrioventricular septal defects or endocardial cushion defects. And in the complete form, this gives you this big hole here in the center of the heart that actually allows communication between all four chambers through the center of the heart. And then for ventricular septal defects, we can have, most common are these membranous or perimembranous defects that occur up here in the thinnest portion of the interventricular septum, but you can also have muscular defects that occur through the muscular region of the interventricular septum. All right, so let's start with this case. So what kind of view is this? What kind of study, what kind of view? Yeah, so it's a three-chamber view, so we're looking at a bright blood MR. This chamber is left atrium, this guy, aorta over here, right ventricle. So does anybody see an abnormality?
Yes.
Yeah, so, I mean, there's a little bit of aortic regurg too, but here you can see that there's you could see the jet here going from the left ventricle into the right ventricle. So here's a ventricular septal defect. So what kind of ventricular septal defect do you think that is? Membranous. You can see it's going through the thinnest portion there of the interventricular septum. The four types of ventricular septal defects, well, first of all, the most common is membranous or perimembranous. What are the other types of ventricular septal defects?
Outlet.
You can have an outlet defect, you can have a muscular defect, and you can have inlet defect, right. So the outlet defects are associated with what other disease?
Tetralogy?
Tetralogy of Fallot, right. Those are the diseases, that's the typical disease associated with an outlet ventricular septal defect. The inlet ventricular septal defect is associated with endocardial cushion defects, right? So you have the different parts of the interventricular septum. We have the outlet portion here, we have the membranous portion here, and then you have the inlet, which is near the inlet valves. Remember, the endocardial cushions contribute to the formation of the septal portions of those inlet valves also. And then you have the muscular portion also of the interventricular septum. So the outlet ventricular septal defects, also called conal defects, are associated with tetralogy of Fallot. So those are very high within the ventricle. They can be characterized as supracrystal or infracrystal, depending on their relationship to the crista supraventricularis, which is a trabeculation in the outflow tract of the right ventricle. Most common are the ones in or around the membranous portion of the ventricular septum, and then we have inlet VSDs associated with endocardial cushion defects, and then the trabecular or the muscular defects. And sometimes there may be more than one, and that can be called the Swiss cheese septum. Now, if we look at the right ventricular portion here of the interventricular septum, here's the left ventricular portion of the interventricular septum. So your outlet defects occur here. They can be above the crista supraventricularis or below there from the right ventricular side. Here's the opening on the other side. And then your perimembranous defects occur through the thinnest portion, through the membranous portion of the interventricular septum. Your inlet defects occur near the inlet valves to the ventricle, okay? And then the muscular defects occur through the muscular portion of the interventricular septum. So when we have a supracrystal ventricular septal defect, you can see here that they are injecting the left ventricle, and the contrast goes preferentially right into the outflow into the pulmonary artery before it actually fills the left ventricle. So that can be a sign of a very high or supracrystal ventricular septal defect. Now, what valvular problem can occur associated with supracrystal ventricular septal defects?
Aortic regurg.
Aortic regurg, right. So that defect occurs right under the aortic valve, right? So you can get prolapse of the sinus of Valsalva into the defect. There's good news, bad news. The good news is it might contribute to actually decreasing the amount of shunting that occurs through the defect. The bad news is that it can be associated with aortic valvular regurgitation. All right, so that can be, so these supracrystal VSDs can be associated with aortic valvular regurgitation. There's a nice example here. So you can see prolapse of the sinus of Valsalva through this ventricular septal defect here into the right ventricle. And you actually see like there's aortic regurg going into the right ventricle. So that contributes, of course, to the left to right shunting. So by the way, these questions are open to everybody out there, even out in virtual land. So if you can answer my question, please jump in and answer the question. All right. So membranous ventricular septal defects, fortunately, those are usually pretty small. So here's an example of an opening there, and you can see how it goes through from left to right, filling the right side. And then this is an example of multiple defects here through the trabecular portion of the interventricular septum. Okay. Now, a small VSD is when the area is smaller than the area of the aortic sinus. A large VSD is called a non-restrictive VSD, so that's where it's larger than the aortic annulus. So that results in equalization, actually, of pressures between the ventricles. So the pressures in the right ventricle can be similar to the pressures in the left ventricle. Well, if we have a large VSD, and if there's equalization of pressures between the ventricles, why does this produce a left to right shunt?
Left ventricle is stronger than the right ventricle?
No, there's equalization of pressures.
But like the myocardium is stronger, so it contracts more?
Again, there's equalization of pressures on both sides. Why would the flow be preferentially into the pulmonary artery?
The pulmonary circulation is lower resistance.
Yes, the flow follows the path of least resistance. So because the pulmonary vascular resistance is lower than the systemic vascular resistance, even if you have equalization of pressures in the ventricles, the flow will be preferentially towards the right circulation. So the volume of the left to right shunt through a ventricular septal defect is related to the size of the ventricular septal defect, but it is also importantly related to the pulmonary vascular resistance. So if you have low pulmonary vascular resistance, you will have a larger shunt. Now what eventually happens is the pulmonary vascular resistance starts to rise as the patient develops pulmonary artery hypertension, and that can actually decrease the amount of shunting. So again, good news, bad news. So good news is it decreases the amount of shunting. The bad news is now you start to develop irreversible disease within your pulmonary vasculature, okay? So small VSDs usually do not produce radiographic findings. We've said that when you have these left to right shunts, you need at least a 2-to-1 shunt before we actually see changes on the radiograph. So ventricular septal defects is the most common congenital heart disease in children, also associated with bacterial endocarditis. Most isolated small perimembranous or trabecular VSDs will close spontaneously. 75% can close by age 10. Now, because the pulmonary vascular resistance is elevated at birth, whenever you have a left to right shunt, it may not manifest clinically or radiographically in a newborn. So here's a newborn with a VSD and the pulmonary vasculature looks okay, but as the pulmonary vascular resistance starts to drop in the newborn period, now you start to get the manifestations of the left to right shunting. So at 11 days, you can see now that there's pulmonary overcirculation from the left to right shunting, okay? A small VSD is not going to produce any radiographic findings, so that's why we're not surprised if they tell us there's a VSD on echocardiography, but the chest x-ray looks perfectly normal, all right? Now, what are the radiographic findings associated with a ventricular septal defect? On chest radiography, what are the findings associated with a VSD? Again, when you're doing congenital heart disease, we always start with, so the pulmonary circulation will be increased, right? So there's over-circulation, increased pulmonary blood flow. And what about chamber enlargement? What are the chambers that will be enlarged? So the left atrium will be enlarged, and you can see here the indentation on the esophagus, right, from left atrial enlargement. What else? Yeah, both ventricles, right? So biventricular enlargement and enlargement of the left atrium. So we kind of covered that last time also, all right? So biventricular enlargement of left atrium with pulmonary overcirculation. So here's an example of a large VSD. And if they're large enough, they can result in failure and ultimately in Eisenmengers when you have large ventricular septal defects. Another example of a very large one with lots of big pulmonary arteries and overcirculation there. Now, the degree of cardiomegaly is proportional to the amount of overcirculation. If there's decrease in pulmonary overcirculation and cardiomegaly, again, might be good news, might be bad news. Might be good news if there's spontaneous closure of the VSD, but it might be bad news if what's happening is we're developing pulmonary artery hypertension and that increased pulmonary vascular resistance is decreasing the amount of left to right shunting now through the pulmonary circulation. And then that means you're getting into Eisenmenger's territory, and then we'll see very large pulmonary arteries and dilatation of the right ventricle. Now, a closure of a ventricular septal defect is contraindicated when your pulmonary vascular resistance gets above a certain amount. So if that ratio of pulmonary vascular resistance to systemic vascular resistance is greater than 0.5, then closing the VSD is contraindicated. Why is that? Anybody? What? What happens to the right heart? And? Why does it fail? Well, the problem is that when the pulmonary vascular resistance is very high, the blood flow through the pulmonary vasculature has become dependent on the left ventricle, pumping that blood across and then through. If you close the VSD now, the pulmonary blood flow becomes dependent on the right ventricle. And with that very high pulmonary vascular resistance, the right ventricle fails. Okay, so that's when you can get into this irreversible territory where the only solution would be a heart-lung transplant at that point. Okay, so I'm showing you an angiogram here. This is a patient with a ventricular septal defect who has Eisenmenger's. How do you know this person has Eisenmenger's? Looking at the images.
contrast in the aorta.
Yeah, so what chamber is being injected?
The right ventricle.
Yeah, the right ventricle is being injected here, and the contrast should go out, and you see that huge pulmonary artery here, but you also see it going across and going into the aorta, as is diagrammed here, okay? So it's going out into the aorta here through the ventricular septal defect. So there's right to left shunting now, okay? So that's Eisenmenger's. All right, different types of the VSDs that we have here, okay? So this one's an easy one, so that should be muscular. This one, that one looks like it's rather high. That's a supercritical one. It can be difficult to differentiate those from the membranous ones sometimes. But the membranous ones occur through the thinnest portion of the interventricular septum. That's the best. That's of course, through the muscular portion, and then that turns out to be a very high one there. Supercritical. Again, here's another example of a supercritical. You can see here the sinus of Valsalva seems to be coming down very close. So that's an outward VSD. What kind of VSD is this? You can see the defect here on the black blood images. On the bright blood images, you can see the shunting, the jet going from left to right.
Membranous.
Membranous, right. That's a membranous ventricular septal defect. Okay. And then what is this?
Endocardial cushion defect?
Yeah, so this is an inlet ventricular septal defect. Okay, you can see it's very high in the inlet portion of the ventricular septum here. Okay. All right, so let's talk about this case. Now, what kind of view is this? What?
Like a three-chamber.
Three-chamber, right? This one? Four, right? This one is kind of a sagittal view, so we're going through the left ventricle, the aorta, and the right ventricle here. Okay? Does anybody see an abnormality?
There's a contained VSD.
Well, there's something funny looking here. See it? Right? Do you actually see a jet going across there? Yes or no?
It's like a bubble.
Yeah, right. It looks like a bubble, right? But there's no jet going across. So what do you call it if something bulges out like that?
Aneurysm.
Aneurysm, right. Do you know what this is called? Well, it's in the ventricular septum. This is called a
VSD aneurysm.
Septal
ventricular septal aneurysm, right? So that's a ventricular septal aneurysm. So how does this occur? This can be the result of a spontaneous closure of a ventricular septal defect. So remember we said that most perimembranous VSDs close spontaneously, but what can happen is as it closes, a portion of the leaflet of the tricuspid valve might be incorporated into that closure. And when that happens, you're left with a ventricular septal aneurysm. So a ventricular septal aneurysm could be the sign of closed VSD, all right? Okay, now if you're doing MR and we've established that the patient has a ventricular septal defect and they want us to assess the severity of the left to right shunting, how can we do that?
Phase contrast.
So phase contrast, what would you do? Where do you do your measurements?
Perpendicular to the flow.
Where?
So you line it up with the VSD. But
No, you don't go through the VSD. There's too much turbulence there. Your measurements will not be accurate at all. So we do not directly do phase contrast imaging through the ventricular septal defect.
Can you compare like the outlet from the aorta and the pulmonary artery?
Yes, so that's what you do. You look at the flow in the aorta and you look at the flow in the pulmonary artery. So using phase contrast imaging, you measure the flow in the aorta and you compare that to the flow in the pulmonary artery. If you have a left to right shunt, what should happen? Normally, the flow should be
Equal.
the same. They should be equal. But if you have a left to right shunt, what happens?
The pulmonary artery.
Yeah, the flow in the pulmonary artery is greater than the flow in the aorta. So we will take measurements through the pulmonary artery, we will take measurements through the aorta, okay, using phase contrast, and then we compare the flow. So if normally they should be the same, but we see here that the flow in the pulmonary artery is greater than the flow in the aorta. That is our left to right shunt. We can compare actually the amount of flow, and that gives us an idea of what our left to right shunt ratio is. Okay? All right. What about this case? What do we have here?
ASD.
Yeah, so this is large atrial-septal defect. So here we have black blood images, and then here we have our bright blood images showing an atrial-septal defect. Okay? The types of atrial-septal defect. What are the types of atrial-septal defect? Secundum is the most common. What else? Ostium primum, which can be associated with Down syndrome or endocardial cushion defects. And what's the other type of atrial-septal defect?
Venous.
Sinus venosus atrial-septal defects. Right. Those are the types of atrial-septal defects. So the secundum is the most common. The primum defect is associated with endocardial cushion defects. Sinus venosus defects, the most common here occur in the superior portion here, but you can also have inferior sinus venosus defects, which are pretty unusual. So that occurs near the insertion of the inferior vena cava. Right. A little trivia question for you there at the bottom. Lutenbacher syndrome, mitral stenosis with ASD, and with mitral stenosis, because of the elevated pressures in the left atrium, you're actually going to increase the amount of left to right shunting. So that's the significance if you have to have mitral stenosis associated with an atrial-septal defect. So the secundum defect is the most common, that occurs through the region of the fossa ovalis within the middle of the atrial septum. The ostium primum defect occurs here near the inlet portion to the ventricles, and then can be part of endocardial cushion defect complexes. And then the sinus venosus defects occur, usually most commonly very high, near the insertion of the superior vena cava. Now, the significance of sinus venosus atrial-septal defects is what?
Anomalous venous return.
Yes, anomalous pulmonary venous return. Almost all cases of sinus venosus atrial-septal defects have partial anomalous pulmonary venous return. So you want to make sure to examine the pulmonary veins very carefully for the anomalous pulmonary venous return, right? And then we've also discussed in the past patent foramen ovale, which can also be, kind of a defect, I guess, through the atrial septum. So with all forms of ASDs, there is association with partial anomalous pulmonary venous return, but it's almost 100% when you have sinus venosus atrial-septal defects. Again, large ASDs result in equalization of pressures between the atria. Why is there a left to right shunt? Because it follows the path of least resistance, because the pulmonary vascular resistance is lower than systemic vascular resistance, right? If we have a combination of a large primum and a large secundum, you can have what's called a common atrium, where you have one big giant atrium there. ASDs can produce a high-flow, low-resistance shunt those are well tolerated for years. As opposed to VSDs, if there's high flow, they can progress rather quickly to Eisenmangers, but ASDs can progress slowly, and actually this is the most common. The ASD is the most common of the left to right shunts that might present in the adult. Okay, so big hole in the center of the atrial septum. What kind of ASD? Secundum, right. So the secundums are the most common. There is that ratio of males to females. Some association with partial anomalous pulmonary venous return, also associated with mitral valve prolapse, which might be due to the distortion of the geometry of the left ventricle from the enlargement of the right ventricle. So these ASDs produce low pressure, well tolerated, low pressure, low resistance shunts, usually well tolerated. So the development of Eisenmangers is less common than with ventricular septal defect. The radiographic findings of atrial septal defect, we always start with pulmonary vascularity, then will be increased chamber enlargement, right atrium, and right ventricle, right, isolated right heart enlargement. So that's what you see with atrial septal defects radiographically. So the point is the left atrium is not enlarged. So this is the shunt lesion that does not give you left atrial enlargement, isolated enlargement of the right heart, okay, the right atrium and the right ventricle. Now, sometimes they can progress to Eisenmengers, in which case the pulmonary arteries can get really large in an adult, right? So if we're thinking of left to right shunts presenting in an adult, ASD is the one to consider. So pulmonary overcirculation, remember you need at least a 2-to-1 shunt before we see it. Enlarged right-sided chambers, no enlargement of the left atrium. So that's an important distinction between atrial septal defects and some of the other septal defects. Secundum ASD, big right atrium, big right ventricle here, big hole there in the middle of the atrial septum. So now the septum can be very thin, so if we're trying to make a diagnosis with MR for an atrial septal defect, you want to be careful. You want to make sure that you really see it on more than one view or more than one successive image. You want to look for, in addition to the chamber enlargement, you want to see if you can actually demonstrate the blood flow going across the atrial septum. Okay? And so atrial septal defect on MR, big right atrium, big right ventricle. Here's a very clever way of demonstrating atrial septal defect here. So what they've done is they saturated the pulmonary venous blood, put saturation bands on the pulmonary venous blood. So as the pulmonary venous blood comes into the left atrium, it's very low in signal. And then you can actually see it shunting across now, across the atrial septum into the right atrium. Okay?
What do you saturate it with?
Sat bands, just like you use sat bands for neuroimaging when you're trying to saturate out portions of the anatomy, right? So you just put big sat bands over the pulmonary veins. What's the path of this catheter? Well, it's SVC, and then it goes right atrium, and then what? How does it get there? Well, wait, where's it going here?
Coronary sinus.
Coronary sinus is down here, not there, right? Now you can see this in children, right? When we read the radiographs on infants, sometimes the an umbilical venous catheter sometimes winds up over there, right? What's it going through?
Is there a VSD?
Not a VSD, but
ASD?
yeah, ASD or patent foramen ovale, right? The catheter can cross into the left atrium through an ASD or patent foramen ovale, and then the tip can wind up in, you said, Sam?
Right upper lower pulmonary.
Yeah, here it's in the right upper lower pulmonary vein, okay? So that's how you get a catheter like that can wind up in a pulmonary vein, all right? So the catheter goes through an ASD or patent foramen ovale into the left atrium, right upper lower pulmonary vein. Now, angiographically, when you're trying to demonstrate, if you want to demonstrate an atrial septal defect, you want to do this and inject into the pulmonary vein, because that allows the contrast to come down and layer across the atrial septum. If you just inject in the left atrium, the contrast preferentially goes into the left ventricle. Okay? So if you want to demonstrate an atrial septal defect angiographically, it's best to inject into the pulmonary vein, let the contrast come down, and then it goes across the atrial septum, as you see here. Okay? What kind of ASD is this?
Endocardial.
Yeah, so that's associated with that can be associated with endocardial cushion defects, right? So that's an ostium primum atrial septal defect. So again, here this catheter is going through a PFO into pulmonary vein, and then the contrast is coming down now, and now you can see it going across this ostium primum atrial septal defect. Okay. All right, what do we think of this case? First of all, look at that pulmonary artery. What do you notice about that pulmonary artery?
Huge.
Yeah, it's really huge, right? So what's going on with this patient? What does this patient have? Well, what cardiac chambers are enlarged?
Right ventricle.
Right ventricle and
Right.
right atrium, right. You look at the right ventricular myocardium, you also notice that it is,
Thick.
yeah, some hypertrophy of the right ventricular myocardium. So does anybody see what this patient's problem is? What view is this? Four-chamber view. Do you see any problem on that four-chamber view? There's an ASD, right? See it? Right here. What kind of ASD is that? That's a sinus venosus ASD. Are we done looking at the case? No. What do we need to look for now? Partial anomalous pulmonary venous return. Do you see it? Where is it?
Going into the SVC?
Yes, so here on the first image, you see these pulmonary veins are going into the superior vena cava. This has been called a seagull sign. Sometimes, see how it kind of looks like a seagull going into the SVC when you have partial anomalous pulmonary venous return? It can go into the superior vena cava like that. So you make a diagnosis of sinus venosus ASD, almost all those patients will have partial anomalous pulmonary venous return. We need to go back and look very carefully at the pulmonary veins. Nice four-chamber view. There is your sinus venosus atrial defect. Okay. So here you can see it. Often there's more than one pulmonary vein here draining into the superior vena cava. Here on this short axis view, here's the left atrium, here is the right atrium. Notice the contrast is coming down the superior vena cava, and then notice how it is falling into the left atrium. So this is actually called, this sign is called the fall in contrast sign, right? So contrast, remember, is denser than the blood, so as it goes in, it can actually fall to the dependent left atrium through an atrial septal defect. That's what's happening here, right? So that's called the fall in contrast sign. So fall in contrast sign here, short axis view, left atrium, right atrium, contrast falling through the atrial septal defect into the left atrium. And then multiple pulmonary veins here draining anomalously to the superior vena cava. So the sinus venosus atrial septal defect, if we make a diagnosis of that, we have to look very carefully for partial anomalous pulmonary venous return. Radiographic findings similar to secundum ASDs, but again, look for the anomalous pulmonary vein. Right? So sinus venosus ASD, look for the anomalous pulmonary veins. Here you can see anomalous pulmonary vein here draining to the superior vena cava. Right? So you want to make sure that you do that if you see a sinus venosus ASD. Short axis view, this is left atrium, this is right atrium. What is this guy? IVC. What's the diagnosis here? This is an inferior sinus venosus atrial septal defect. So this is also considered a sinus venosus defect. This is unusual because this occurs at the inferior margin of the atrial septum near the insertion with the inferior vena cava. Right. So that's an inferior sinus venosus ASD. That can also be associated with partial anomalous pulmonary venous return into the IVC though from the right inferior pulmonary vein. Okay. What is this guy? Yeah, so that's an Amplatzer closure device, so that can be used to close an atrial septal defect. Okay, so that's an occlusion device. And so this is this umbrella-like device that is placed across the septum and then it deploys, and then what happens is these grab onto the rims of the atrial septum, and that's how the device stays in place to close the atrial septal defect. All right. So here it's placed under fluoroscopic and echocardiography guidance. There's your ASD. There's the device going across the ASD, gripping the rims of the atrial septal defect, and that's what keeps the device in place. So this is a transesophageal echo probe, right? And here they are deploying the device across this atrial septal defect. And you can see when it expands, the idea is that like an umbrella, these things expand and then grab onto the rims of the atrial septal defect. So easy to miss on the frontal view, but on the lateral view it looks like that, right? So if you see this, you recognize that as an atrial septal occlusion device, okay? And this is what they might look like radiographically, all right? Now, what should be evaluated if we're looking at an ASD and we're evaluating it for potential closure with this device? What are the things that we want to look at? Well, of course, you want to look at the size of the atrial septal defect. That's important. The other thing you're going to look at is you're going to look at these rims, right? There has to be enough tissue in the rims for the device to hold on to. Otherwise, the device will not stay in place. Okay? We need to measure the size of the atrial septal defect. Right? So my question for you, so here's the atrial septal defect there I've outlined for you. Does the phase of the cardiac cycle matter if you're measuring an atrial septal defect? Is an atrial septal defect larger in systole or diastole? Anybody else have a guess?
Systole.
There's a systole, there's a diastole. Where's it bigger?
Systole.
Systole, right. Remember, in systole, the valves are closed. There's no place else for the blood to go except across the atrial septal defect. All right, so you want to make sure that you measure it when it is the largest, because this device needs to be able to close the defect. All right? Now, the other thing we need to measure is the rims. So you need to find the rims of the atrial septal defect. There's an anterior superior rim near the aortic valve. This patient actually has a deficiency here. There's no rim here, which is a problem if you're going to place the device in this patient. So this patient would not be a good candidate for the device. There's an anterior inferior rim near the tricuspid valve, posterior superior rim near the superior vena cava, and a posterior inferior rim near the inferior vena cava. So you look for these rims, you want to measure these rims, and you have to assess all four rims. So here's the inferior rim, there's an inferior rim posteriorly. But here, as we look near the aorta, there's a deficiency of the anterior superior rim. So deficiency is if the rim is less than 3 millimeters. So that can be a problem. So you don't have a rim for the device to hold on to. Right? So here's that rim deficiency. So this patient, not a good candidate for the device. Here's a patient where all the rims are intact. So you can see the anterior superior rim, and then here's a posterior rim. So those rims are intact. So this patient would be a good candidate for the device. There are rims for the device to hold on to here, right? This is what happens here with the rim deficiency. Not good, right? Device cannot hold on to. Posterior rim deficiency here. There's a posterior rim deficiency. And this is what happens if you try to put one in on those, it flops out. Okay, bad news. All right, the blood return from this catheter is bright red. Well, the first thing you think when you see a catheter that looks like it's, doing these, going someplace where you don't recognize, is the catheter not in a vessel? Is the catheter free in the mediastinum or going out somewhere in the tissues, right? But here so you need to check for blood return. Well, there is blood return, but it's bright red. Where's the catheter?
Pulmonary vein.
Yeah, so the catheter got into a pulmonary vein. So what does that mean about this patient?
Like a ASD or?
Well, is it anywhere near an atrial septal defect?
No.
No, so this patient has anomalous pulmonary venous return. So there's anomalous pulmonary vein here that's connecting to the superior vena cava, and that's what the catheter got into, right? So it got into that anomalous vein. So partial anomalous pulmonary venous return, these can also be associated with ASDs, but these can be isolated. Usually if they're isolated, the shunts are not large, okay? So these are not associated with large amounts of left to right shunting. So these can return to the superior vena cava, coronary sinus, or any of these other vessels, right? But right upper lobe, pulmonary vein to the superior vena cava, that's one that you should look for. We also see left upper lobe to the left brachiocephalic vein. That's something that we see a lot also, just incidentally on CT. In most cases, these are incidental findings, all right? So this one we see a lot, left upper lobe pulmonary vein draining to the left brachiocephalic vein. And again, usually the shunt is not that large. Here are additional examples. Here's a right inferior pulmonary vein here going to the right atrium. And here's a right superior pulmonary vein going into the right atrium there. All right. So if there is a large amount of shunting, again, we can have findings just like atrial septal defect with pulmonary overcirculation, enlargement of right atrium and right ventricle, right? But as I've said, if they're isolated, usually there isn't enough shunting because you need at least a 2-to-1 shunt before we actually see these changes on the chest radiograph. So here's that case we saw earlier, catheter going out to an anomalous right upper lobe pulmonary vein. Here's another example here, this one going into an anomalous pulmonary vein on the left side as the catheter is sneaking into that, okay? All right, so we have this chest x-ray. Anything abnormal here?
The sickle or the
So what is?
scimitar?
Yeah, this is the scimitar sign, right? So this patient has what then? What does the scimitar mean?
Anomalous venous return to the
To the
IVC.
to the IVC, to the inferior vena cava. And the other abnormality associated with scimitar that you can see on the chest radiograph is what?
A small lung.
Yeah, small lung can also be associated with that, all right? So scimitar, also called hypergenetic lung, pulmonary venolobar syndrome. So that's where you have anomalous pulmonary venous return of the pulmonary veins from the right lung. They drain to the inferior vena cava, okay? So scimitar syndrome, usually associated with a hypoplastic right lung, right? But what we look for on radiography is the scimitar sign, and that's the anomalous pulmonary vein that is draining down into the IVC. Now, there can be other abnormalities that can also be associated with scimitar. Interestingly, most patients with scimitar will have an intact atrial septum. They don't have an atrial septal defect. Okay, so scimitar vein, small right lung. So these are the findings that are associated with scimitar syndrome. And the anomalous pulmonary vein comes down and drains into the inferior vena cava. So the pulmonary venous return from the right lung drains to the IVC. That vein coming down is what gives you the scimitar sign on the radiograph. Okay? All right, so this patient has an abnormal vessel here in the anterior mediastinum. See it? What is that vessel?
Left SVC.
Well, that's the question. Is that a left SVC or is that something else? If it's a left SVC, where should it go?
Coronary sinus.
Yeah, it should drain down to the coronary sinus. Do you see it here on this image at all?
No.
No, so it's not coming down, it's going up into the left brachiocephalic vein. And you can also see branches of pulmonary vessels coming into this vessel, right? So what is this vessel then? This vessel is,
Anomalous.
yeah, that's partial anomalous pulmonary venous return of the left superior pulmonary vein. This is pretty common. You will see this often. It is missed. It's usually an incidental finding, often missed on CT scans, but you will see this if you're just aware to look for it, all right? So this is partial anomalous pulmonary venous return of the left upper lobe pulmonary vein draining to the left brachiocephalic vein. Again, as an isolated anomaly, this usually doesn't produce enough left to right shunting to be physiologically significant, okay? The first thing we check on our ICU films is lines and tubes. What do you think? Left IJ is going where?
Either the aorta or left SVC.
Okay, well, how would it get into the aorta? But usually, but you know, you do have to consider it. Usually when we see this, it's going to a left superior vena cava, right? So here, on that one cut, that can look just like partial anomalous pulmonary venous return. Now I've got arrows pointing to two vessels here, right? What is this vessel? What is this vessel? So what is vessel A, this guy over here? Well,
That one's a left SVC.
okay, and this one is?
The anomalous pulmonary vein.
No. The person has that
That's really
SVC. This guy is the normal left superior pulmonary vein. Remember, the left superior pulmonary vein drains down to the left atrium. So when you have persistent left superior vena cava, you will see two vessels down here. One is the persistent left SVC. The second vessel is the normal left superior pulmonary vein. The persistent left SVC drains to the coronary sinus. Right. Okay. So the anterior vessel here is the left SVC. The posterior vessel is the normal left superior pulmonary vein. Right. So that left SVC comes down then and will drain to the coronary sinus. Okay. So here you can follow it. There is our left SVC coming down, and then two vessels, and then that left SVC drains to a dilated coronary sinus. Okay. So persistent. So when you have a vessel like that in the anterior mediastinum, your two possibilities are persistent left SVC versus partial anomalous pulmonary venous return of the left superior pulmonary vein. The persistent left SVC drains down to the coronary sinus, drains down, whereas the partial anomalous pulmonary venous return, that vessel drains up to the left brachiocephalic vein. So when you try to follow it down, there's no vessel anterior to the left upper lobe bronchus because the left superior pulmonary vein that is supposed to be there is draining up to the left brachiocephalic vein. On the other hand, when you have persistent left SVC, you have two vessels here. One is the persistent left SVC, the second is the normal left superior pulmonary vein. So this is how you differentiate persistent left SVC from partial anomalous pulmonary venous return. Okay? And then, this is all the stuff that we've kind of gone through in terms of differentiating. Also, the coronary sinus is enlarged when you have a persistent left SVC because it is draining to the coronary sinus. Okay? What is this?
The mono.
Well, yeah, I mean, notice that you have all four chambers that are kind of communicating there in the middle of the heart, right? And then you have this one large common bridging valve that seems to be going across the middle of the heart. So this represents what?
It's like a,
Remember, what part, embryologically, what contributes to formation of the interventricular septum and interatrial septum in this region? Endocardial cushion. So what are we looking at? This is a complete endocardial cushion defect. So you're looking at a complete endocardial cushion defect here. Okay? So these are endocardial cushion defects. With the complete defect, you could have a big hole in the center of the heart where potentially all four chambers can communicate, and you might have one common bridging valve going across that hole. That is a complete endocardial cushion defect. All right? So we can have partial defects or complete defects. So these can be associated with trisomy 21 or Downs. So it's the complete defect where you have a common bridging valve going all the way across. So I've given you all the diagrams kind of explaining the differences between the partial defects and the complete defects. The complete defect, if they show you one, they'll probably show you a complete defect, so that's the one that you want to be able to recognize as the complete endocardial cushion defect associated with trisomy 21. Okay? So partial defects can be milder and they can simulate atrial septal defects, whereas the complete defects simulate large ventricular septal defects. All right? So the complete defects will give you pulmonary overcirculation in large chambers, and if there's communication of all of the chambers, you might actually simulate or give you kind of like an admixture lesion where you have bidirectional shunting with complete endocardial cushion defects. So lots of pulmonary overcirculation because of the left to right shunting here. Partial defects can simulate ASDs. They will be milder, whereas the complete defects simulate VSDs. Now, with all of these defects, another hallmark of endocardial cushion defect is what's called the gooseneck deformity. So looks like there's this elongation of the outflow tract here of the left ventricle. So that's called the gooseneck deformity. That is associated with endocardial cushion defects. So they might show you that. So the complete defect, you want to be able to recognize that if you're shown that on imaging. The gooseneck deformity is the deformity here, this elongation of the outflow tract, which is also associated with endocardial cushion defects. So again, big hole in the center of the heart, common bridging valve going across the center of the heart. Those are the findings of a complete endocardial cushion defect.
The common valve would be like the mitral and tricuspid, just like fused.
Right. This case demonstrates communication between what two chambers?
Left ventricle, right atrium?
Yeah. So right through here, right? Left ventricle, right atrium. So an isolated anomaly in this region does have a name. What is it called?
Atrioventricular septal.
Yeah, it's an well, remember, atrioventricular septal defects won't be used for endocardial cushion defect, but the term for this is called a Gerbeau defect, all right? So remember, because the tricuspid valve is displaced normally just a little bit towards the apex of the ventricle, there is this portion of the interventricular septum, that membranous portion that is very thin here, where if you put a hole in the right place here, you can get communication between the left ventricle and the right atrium. So a congenital defect in that region is called a Gerbeau defect. Okay? What's wrong here? pulmonary artery is really big. Why? Yeah, this is a PDA. So you can see communication between the aorta. Here's the PDA, and it's common for these to calcify in adults. Communication of the PDA between the aorta and the pulmonary artery, right? So that is a PDA. And again, these can calcify in adults. Notice the big pulmonary artery here from that PDA. So PDA, these usually these can produce large shunts. These are most common in premature infants. They can produce high flow, high pressure shunts. So if they're very large, they need to be fixed, right? So you can demonstrate it nicely with MR, that you can see the shunt flow going through that jet between the undersurface here of the aorta, and there's the enlarged pulmonary artery. And these can cause Eisenmengers if there's enough shunting, and can also be associated with infective endocarditis. And cardiomegaly will be proportioned to the amount of overcirculation. So here's an example. You have a big pulmonary artery here, big pulmonary arteries from the left to right shunting. Right here, notice that calcification in the AP window. That is calcification of a patent ductus arteriosus in this patient. Okay? And this patient actually developed Eisenmengers or presented with Eisenmengers. So that calcification in the AP window here is calcification of the ductus arteriosus. And so on MR, pretty easy to see this, right? You can see the flow going across from the aorta to the enlarged pulmonary artery. Well, we have a PDA. So your volume rendered views showing you the same thing. And then we've seen this on CT. It can calcify. There's your communication. And then, again, it's common to see these things calcify. If you want to differentiate, though, from a calcified ligamentum arteriosum, you look for that communication, right? The communication going across between the aorta and the pulmonary artery. Also, the pulmonary artery will be somewhat enlarged. So these can be closed with embolization devices in infants. So you might see sometimes when we read these pediatric cases, you might see these funny looking things right there in the AP window. So that represents a PDA occlusion device. Okay? Normal or abnormal?
Normal.
Okay, go. So, what's wrong here?
Well, on the right, it looks like an aneurysm off the aorta, but on the right, and then on the left image, I'm like,
Well, this guy, what is this guy? This guy is pulmonary artery. Yeah, this guy is aorta, right? This is pulmonary artery. So the pulmonary artery is, aneurysmally dilated here, but what's going on between the aorta and the pulmonary artery? What do we call this? So what is this called? There's a term for this. No, well, yes, and this is called an aorticopulmonary window, right? So that's an aortopulmonary window, aorticopulmonary window, okay? So functionally, these are like PDAs, but they're communications between the ascending aorta and the pulmonary artery, right? So it's caused by deficient septation of the truncus arteriosus. It results in a large communication between the aorta and the pulmonary artery. Both semilunar valves are present. So that's what distinguishes this from truncus arteriosus, right? Truncus arteriosus, there's just one vessel. Here, there are really two vessels that communicate through that defect there. Right? So that's called an aorticopulmonary window, physiologically similar to a large PDA. Unfortunately, these patients, if they're not found in time, will present with Eisenmengers. Often it's too late for these patients. So physiology, like a large PDA, we will have overcirculation, and they can go on to Eisenmengers if it is not corrected. So the differentiating from PDA, the communication is between the ascending aorta and the pulmonary artery for this. So communication between the ascending aorta and the pulmonary artery for aorticopulmonary window above the aortic valve. Right. So make sure that you know what chambers are enlarged, depending on the different shunt lesions that we are talking about here. So for this case, pulmonary circulation is Increase the question you ask.
Cyanotic.
Patient is not cyanotic, so in the category of left to right shunts. So looking at the radiograph, what do you think, what chambers do you think might be enlarged here? Left atrium, left ventricle,
Right ventricle.
right ventricle maybe. So what lesion are you thinking about?
VSE.
Yeah, so this was a ventricular septal defect, okay? In this case, again, there's overcirculation, no cyanosis, okay? So for this particular patient, notice that the ascending aortic here looks enlarged, left-sided chambers look enlarged, so here you might be thinking about PDA, right? So that's a PDA. In this case, overcirculation, is the left atrium enlarged?
No.
No, so here you think about
ASD.
ASD, right? So that's an atrial septal defect, okay? And here, what do we have here? Remember I told you about this? What was that called?
Cushion.
Yeah, so that's called a gooseneck deformity. So the diagnosis here is, yeah, this is a complete endocardial cushion defect, okay? All right, so that's our discussion of left to right shunts, so there will be a quiz next week.